Okay, so this is our third episode of the podcast. We've got Martin Klinker with us, who's an orthopaedic foot and ankle surgeon, and we're going to talk about one of our favourite topics today, or I don't know if it's favourite, but certainly one of the most common conditions that we see across the board, which is the dreaded policeman's heel or plantar fasciitis. So we're going to talk about diagnosis, treatment options, and hopefully people will find this useful if they are suffering with plantar fasciitis, which, let's be honest, actually can be a very debilitating condition. So let's first of all start with, what is plantar fasciitis, Martin?
Well, so I'm Martin Klinker, a foot and ankle specialist, but also sports medicine specialist, and only see pathologies below the knee. So Achilles tendon and plantar fasciitis, and often they're linked together because the plantar fascia is more or less a continuation of the Achilles tendon. When you get an MRI scan, you can see that the tissue goes around, so therefore they're often linked together. So the plantar fascia is a passive structure that supports the arch. We have the muscles, we have active dynamic structures, but the plantar fascia is a very strong tissue, like a ligament, very strong, and it attaches at the heel, goes to the forefoot.
So it goes all the way along the bottom of the foot.
All the way, and it supports very much. And we're supposed to do 10,000 steps a day, and people walk a lot, most of the times not in the right shoes probably, and especially in London on hard surface, not out in the countryside, not barefooted. And that puts a lot of stress on that small part. And yes, some people try to avoid running on the heel, but more on the forefoot. But even then, that puts a lot of stress on the plantar fascia because it needs to support. And as we push off, we go into that stiff position of the foot, and that's where the plantar fascia again takes a lot of stress. So pushing off with the foot running can put stress on that as well, even if you don't land on it. If you land on the heel, of course, there's stress on the heel bone and on the plantar fascia, but pushing off causes stress on that area as well. So it's a very, very common condition. Why? Because we put a lot of stress to that part of the foot. Policeman or postman syndrome, because it's linked to standing, can be linked to walking as well, doing push-off phase, but standing then makes it even more painful often. Yeah. So it's a thickening, often an inflammation, and the signal is different when you get an MRI scan or ultrasound scan, or the structure at the attachment towards the heel.
Yeah. So it very much is thickening of the plantar fascia where it attaches onto the heel, and most people have that pinpoint pain, don't they, on the heel bone. And a lot of people, or classically, not always, they will have that start-up pain. So they get out of bed in the morning and they really look like an old man or woman because they're very much limping. But the good news is, give it 5-10 minutes. Normally, it starts to ease up, doesn't it? And then they'll probably get going. Then they go and sit on the train for half an hour. They don't feel it. Then they get up. So it's that start-up pain, which is quite classic. And often you find it does improve during the day, but then you're going through this process again every day and it gets quite tiring.
Especially if they wake up in the morning, they feel the discomfort, but then going downstairs, that's where you need most flexibility. That's when it's most painful. They feel like an old person going sideways, and that is frustrating to them. So yes, that makes a big difference. When you feel the pain in the morning, each time they stand up, they start walking, that's an issue, yes. And as with arthritis, it tends to get a bit better when they're warm, when they walk, and sometimes they can even run.
Yes,
they run,
absolutely.
But they can't walk that much. And on the weekend, they try to do a bit more, and they might get even more pain because they try to do something that they couldn't do during the week. So especially if they do impact exercise when they play tennis or something like that.
Absolutely. So I suppose we should probably talk about, how do you diagnose plantar fasciitis, and probably what do we need to make sure it isn't if the pain has actually been going on? Because if something's been going on a while, you've got to get it checked out. But what else could it be, and how do we diagnose plantar fasciitis?
It's very common. 10% of the UK population gets it once in a lifetime normally. It may last a few days because it's just been a bit of an overload in that area, but it can go on and on and on. And there are various treatment options then available. So it is common. So most of the times it is likely that heel pain is plantar fasciitis, but it could be something different as well. So we know under the heel is a fat pad, and we need that fat. We always want to get rid of fat, but that fat we need. So when we...
It doesn't matter how much you don't eat, it's not going anywhere.
Exactly. But we need it under the heel because it's a different kind of structure of the fat. It's cushioning. It's a proper cushioning fat pad. And when people suffer an injury, they're landing from a height and they crush the fat pad, they're really in trouble. Don't have to break the bone can heal, but the fat pad can't heal. So it could be an inflammation of the fat pad, the plantar fascia might be normal.
And you would treat them potentially different, wouldn't you? So therefore it does need to be correctly diagnosed.
That is injured,
difficult.
bad diagnosis.
Yeah.
You can do things, but you can't restore it. Plantar fasciitis we can treat, yes, but it could be the bone where it attaches to. So it could be the bone itself, or they might have grown a little spur, or the spur has always been there. We shouldn't too much focus on the spur, but it might be linked to that, especially if we were to get an MRI scan, and we saw on the MRI scan there's an increased signal, there's more fluid in there. That spur might be also responsible for some pain, but it can be the bone itself.
Yeah.
I remember having a young lady, active lady, and she had pain exactly in that spot. She described everything, but I thought,
wasn't quite right.
get an MRI scan straight away.
Yeah.
And she had 2 stress fractures.
Wow.
One in the
calcaneum, so
in
the
the
heel
calcaneum,
bone.
and the second one in the distal tibia.
Wow.
I saw that
Yeah,
incidentally. Didn't complain really of pain. But yes, she had pain exactly, and when you saw the fracture line, it ended up where the plantar fascia is.
Yeah.
But she wasn't. She was getting worse and worse and worse. She couldn't run. It wasn't the typical history. So the history tells you a lot.
Yeah.
Morning pain. She didn't have too much pain in the morning because she didn't weight bear straight away a lot.
So it was
got
only
worse
when she
and worse
impacted.
and worse. Exactly.
Yeah.
With the running, with the walking, she got worse and worse and worse.
Yeah.
So it's not like always in the textbook, but often the morning pain is normally linked to plantar fasciitis.
So the key message there, and I totally agree, I can think of a couple of people just this year that referred in for plantar fasciitis. One was actually referred for a steroid injection. Just like you, it just didn't sound quite right. Runners as well, and they both ended up having calcaneal stress fractures. So it definitely needs to be ruled out, doesn't it? Because that does need to wear a boot for a period of time and a period of offload. The other, and both of those patients were runners. They were both female, and they both had low BMI. And
Same
obviously
one.
the same as you. Yeah. So certainly with that group of patients, they are a risk factor for a bony injury, aren't they? And that definitely needs to be ruled out. Okay, and in terms of actual diagnosis of the plantar fascia, how would you do that in clinic?
Well, it's normally that one spot which hurts. The axial compression, you need to do that to see is it likely to be a stress fracture.
Yeah.
That's
when you squeeze the bone.
Squeeze on either side, the heel. You want to see, is it hurting a bit further down the foot? Is it in the midfoot? Because the vast majority is at the heel, probably 5 to 10% a bit further down, and some 5 to 10% in both places.
Yeah.
But if we see that further down the foot, in the middle of the arch, there's some thickening, this is not plantar fasciitis.
And that would be a plantar fibroma?
Exactly.
Yeah.
It's a plantar fibroma.
Yeah.
Plantar
So that's where it's not,
fibromatosis.
it's sort of in the middle of the arch,
And
isn't it? It's further down.
You can feel that thickening.
Yeah.
Plantar fasciitis, you can't see or feel that thickening.
Yeah.
So if someone comes in with that, it's always in the non-weight bearing part of it.
Yeah.
The thickening, plantar fibromatosis, was at the heel. Plantar fibromatosis doesn't exist there.
Yeah.
So plantar fasciitis is normally at the heel, but you got to test further down as well.
Yeah.
You want to test the flexibility of the calf muscle.
Yeah.
You want to see is
Very
that
important.
probably a reason why they have that. And then I have it, you have it as well. An ultrasound scan can be extremely helpful.
Yeah.
You check with the ultrasound scan, is there some
And
thickening?
it takes about 10 seconds, doesn't it, to confirm the diagnosis.
Takes me 20, but for you 10.
But you'll get there, Martin. And the other thing is with ultrasound, you can compare to the other side.
Always.
And normally what you
Clinically,
see is you see that thickening. And also sometimes it can be useful to see how thick it is, and that might help with your prognosis, but not always. And obviously to see if there's a tear, particularly if they've had an incident where they've suddenly run across the road and felt something go, because we would treat that quite differently, wouldn't we? That would need to be immobilized potentially for a period of time. Okay, so let's imagine somebody's got plantar fasciitis. Where would you go with it first? How would you treat it?
Well, they need to be aware of it. They need to know that it's nothing malignant, nothing to worry about.
Yeah.
But if you don't treat it, I mean, you can do everything you want to. You're not causing any proper damage.
Yeah.
It could rupture. I've seen ruptures even without any activities.
Yeah.
A few, not very common. But it's very likely you continue to have pain. It is likely to disappear at some stage, but you delay that period. There's no clear proof that by doing something, it will dramatically shorten, but you should have less pain and less time where you have the issues with.
Yeah.
So what should we do? Well, we got to examine them.
Yeah.
We have to see how tight is the calf muscle, because as I said, it's the same tissue, but also the tighter the calf, the less flexibility there is.
Yeah.
And the less flexibility in the ankle joint, the more flexibility needs to come from the foot. That means there's more stress on the plantar
So a
fascia.
stiff ankle joint definitely can predispose, can't it?
Absolutely.
Yeah.
So, but that does not mean that they have to have an overall stiff foot. It can be a very flexible, flat foot, but not enough dorsiflexion.
Yeah.
And that puts a lot of stress on the plantar fascia.
Yeah.
So therefore, we need to check that and then focus on that.
Yeah.
So yes, they need to learn how to stretch properly, physiotherapy. They need to work on their muscles. They can sit at the desk at work, take at first a golf ball, then a tennis ball, and then a golf ball, massage or a spiky ball, a bottle, a can of whatever. They can do that. I think the golf ball is probably the best one because it's
I'd
more,
agree.
smaller, but they can have it in the pocket to go somewhere, sit and just massage it regularly. They shouldn't overdo it. Some sporty people always think I got to do a lot. No,
The
it needs
more
to
the
be,
better, but not
no,
always.
it isn't.
Is it?
No.
And we also find that the stretching is important, but there is some evidence, isn't there, that strengthening the calf, particularly with the toe and extension, can help. But obviously, as a physio of nearly 25 years, I've had some successes, but it doesn't get everybody better. That's
There's nothing that gets everybody better. There's some treatment options which are more likely to work.
Yeah.
So the patient who says, my main issue is I get up in the morning, I can't walk. I have so much trouble going downstairs. Those patients might benefit from a night splint.
Yeah.
That stretches the calf.
So that's a good one. It's not something that it used to be used a lot more, didn't it? A night splint. So was it a Strasbourg sock?
There is the Strasbourg sock, which by definition is a fairly good one.
And that's
it's
where
soft.
you sleep with your toes up
Exactly.
towards your shins, basically.
The benefit
not
of that
very
is
attractive.
No, but better than the ones that have plastic.
Yeah.
And you touch the other leg and it's always painful.
Yeah.
The Strasbourg sock, it's just a sock, so it's good, but it pulls up the toes because it's at the tip of the toes that is attached to the tibia.
Yeah.
So it pulls up the toes, which is really unpleasant. So there are some patients who can sleep even with a Strasbourg sock, and they might benefit. But if you can't sleep because you have a night splint, it doesn't work.
And I've found over the years, I've had lots of patients that have bought it on Amazon and tried it, and some people have found it very useful. Some definitely haven't, but they've often said that it helped their morning stiffness a bit, but not the rest of the day pain. So there may be a role, mightn't there?
Yeah.
Footwear is obviously really important. Some people like to wear a little heel raise or a cushion pad. Again, I've probably had as many people say it's helped as they've said it hasn't helped, but most people would probably try that. That seems like a sensible option. And the other one, which is definitely linked, is to try and lose weight. And there's definitely it's definitely a risk factor, isn't it? That if you are quite heavy, then obviously you're putting more force through your plantar fascia. So that's another sort of motivating factor to try and lose weight with these things, because we generally know it's going to go, don't we? The problem is it could take 2 months or it could take 2 to 3 years. So let's say that a patient has tried the stretching, tried the strengthening, changed their footwear, done the Strasbourg sock, lost a load of weight, modified their activity a little bit. What are the other options that you might suggest? We certainly use shockwave. What's your opinion on that? Injections, surgery as well. Where would you go with that?
I still think that footwear makes a big difference.
Yeah.
A quick one on that. A bit of a heel raise, the right shoes.
Mm-hmm.
Women, not high heels, but ballerinas even worse.
Yeah.
So they think they help themselves by not wearing high heels, but no support is even worse. So I'd rather have a woman wearing a bit of a heel.
Yeah.
They want to hear that. Losing weight, they always say, well, I can't lose weight because I can't walk.
Yeah,
so that's another issue.
That's fair, isn't it?
Doing non-impact exercise, but I can't go cycling for 4 hours. I could run for an hour, I can't, blah, blah, blah. So, but it's right, doing all these things. But yes, it's so common you see it in the skinniest people even, because they don't have enough fat pad underneath to protect and cushion that. No, but after a certain time you've done everything, the patient has done everything, yes, there are some other options. So the next ones are then either shockwave treatment or a cortisone injection, ideally ultrasound guided.
Yeah.
They have their benefits and their downsides. They seem to work, according to the literature, 70-75%. But it's tricky.
I think that's definitely my experience. It's
tricky to know, but they need to know why one or the other might be better for them. So the benefit of the injection is it works fairly quickly. You do it ultrasound guide, they come in, you do it, and it works quite well. It can be unpleasant because cortisone, as in other tissues, can crystallize, and you put fluid in an area where there shouldn't be any. That can hurt. It doesn't last very long, but the patient needs to know about it. It is quick, and some people really, they're so much better soon.
Yeah.
There is that very, very small risk, but there is that risk that it could lead to a rupture of the plantar fascia at that heel level. It might not happen the next day, it might happen 2, 3, 4 months later. But if the patient knows about it and they decide, I want to have that done, it doesn't happen often, but they need to know about it.
Absolutely.
The benefit of shockwave treatment, which you use, I use, I think it's very good, it's safe.
Yeah.
So
and non-invasive. You don't need to stick anything in anywhere.
The risk is when you're on blood thinning medication, you can't use it on pregnant ladies for whichever reason. You can't use it if they recently had a cortisone injection. We don't know exactly for how long.
Yeah, we say 3 months, don't we? But I think that's
yeah,
made up.
Yeah, I think
there's no literature to support it.
There isn't any. I think 6-8 weeks is fine for me.
Yeah.
So shockwave treatment, I think, is a good option because it's safe. There's no real risk. It can be quite unpleasant, but it doesn't last. Once you finish, 3.5, 4 minutes, 5 minutes, depends. The pain that you cause to the patient isn't there anymore. It's not healed, but that pain disappears. You need to do 3, 4, 5 sessions depending on the patient as well. And yes, it works quite well, but it takes longer for the benefit.
Absolutely.
So
Probably 6 to 8 weeks really,
after the last session.
To get 50 to 70% benefit.
Exactly.
I don't know, but something like that, isn't it?
I have the impression that those who come back and they say the first one made a bit of a difference, they're more likely to work.
Yeah.
The ones who come back and had 5 sessions, it hasn't worked. Will it work? It might.
It probably has a ceiling effect, doesn't it?
It certainly has. But the ones who feel some benefit, I know patients who had it, they were absolutely fine. They had a bit of pain. They came back, can have some more because it worked so well. And
the key thing is, if you're going to consider shockwave or an injection, is that you've probably had some sort of imaging to confirm it. Because what you don't want to do is shockwave a stress fracture, inject a stress fracture, or particularly with the shockwaving the inflamed fat pad. I mean, the patient would just jump off the bed, wouldn't they? My experience of shockwave is that certainly if I had plantar fasciitis, I would try a shockwave before an injection.
Me too,
But I saw a patient, I think it was on Monday, yesterday, where I offered shockwave and they were just not interested. They were depressed, they were low, as in they just want, I remember her, she literally said, I can't cope with this pain anymore. I counselled her on obviously whether or not, with the small risk of a rupture, and she made her own decision. And that's what we can do, isn't it? Is we just have to give patients the information. It does make sense if you can to start with the least invasive first. But obviously some people, are really struggling with the pain, and it can be very debilitating, and this lady wasn't able to go to work because of it. So when you weigh it all up, you totally understand that she makes that decision. And then obviously in the physio clinic we will always follow that up with the strengthening exercises of the calf and the plantar fascia. Any other, so let's go on to surgery. So we've sort of covered, actually 2 questions. One is this something that you do find orthotics help, so seeing a podiatrist? And do you ever do surgery for the plantar fasciitis patients?
I've done it.
Yeah.
I can't remember exactly when.
No, so it's a while back.
It's ages ago. And we know from the literature, again, 50% are better after 6 months. If you don't operate, 50% are certainly better after 6 months.
Right.
It's really for those who had it for ages.
Yeah.
That might benefit from surgery, but I haven't done it probably for 10 years. I haven't done surgery on the plantar fascia for 10 years. Yeah. What I've done is release the calf muscle because of the tight calf muscle. And that is something I sometimes combine with forefoot surgery. Yeah. And patients say, bunion doesn't hurt, metatarsalgia is better, but my heel, my flexibility is so much better. So it's a very small operation. We release the calf muscle. We don't cut the Achilles tendon. We only do one part of the gastrocnemius, the medial gastrocnemius, the aponeurosis of it. We do it on both legs normally, and that gives more flexibility. That doesn't straight away take away the pain. I had a patient and it didn't work, and he came back years later for some completely different, again, he's going to complain.
Yeah,
I still
yeah.
have it. Came for a different reason. And I said, how's your plantar fascia? Did I have it? Oh, yeah.
And
oh,
they
yeah.
can never remember which foot it was.
Which leg
Yeah,
was
yeah.
it? I don't know. Well, I could see.
Yeah.
But no, he was absolutely fine. It took
Yeah.
some time because, yes, you don't operate on the plantar fascia. You give them more flexibility and therefore with time that should get better.
I think
but it's again
that's
a combination.
Key. Yeah.
It's a combination, again, the footwear, relative rest, but stretching then.
Yeah.
So the calf release allows you to stretch more effectively. It
Yeah, yeah.
gets you a lot more flexibility than just doing stretching.
Yeah, yeah.
And therefore, I think it can work quite well.
Yeah.
But I haven't really operated and cut the plantar fascia
Yeah.
with a knife, which it's not really recommended
No,
anymore.
no. Well, if you haven't done it for 10 years, it probably wasn't one that you want to go back to. So I'm just thinking now, I think the message really is that obviously you've got to rule out the stress fracture, you've got to rule out the other stuff. Patience is probably really important.
Very important.
And actually patients, as in patients, are often very reassured when you say, look, it must be 90, 95, even higher percentages than 95% do get better.
Yeah.
You almost need to just ride it out, really. And it seems to be, people use the term self-limiting, so it does go. But it can take time, and it can be very debilitating, can't it?
Yeah.
I think injections have a role, shockwave has a role, surgery obviously not so much so. One of the things that I often find is that patients that run or walk have really limited their activity levels because of the pain. And I think that's the fear that the pain, and you alluded to it earlier, is that whether or not that pain is causing them any damage. So what's your opinion on that? We quite often get the, patient saying, well, can I still run? Can I just run with this pain? What's the worst that's going to happen? How would you normally answer that?
The worst is it can rupture.
Yeah.
Because it can. A structure that is not looking well and you run can cause a rupture. It depends on how you run. If you do an activity where you have a sudden impact on it, you're jumping, you're landing on it, you're playing basketball, tennis, those activities are probably more likely to lead to a rupture.
So stuff involving impact.
Exactly.
Yeah,
Whereas you continuously run, the way I used to jog, couldn't. Too slow, too little stress on it.
Right, yeah.
You land on it, that causes pain, but it needs to be properly stretched out
Yeah.
for it to rupture. So I wouldn't recommend it. And I always tell the patients, the pain feedback is important. Those patients who lose the pain sensation, diabetics, or who have a neuropathy, they cause damage to themselves because
That's
they
a good point.
can't listen to their pain. So we want to get that bit of pain feedback. So if it's a bit of discomfort, the risk is you're going to delay your recovery, but it's still likely to get
recover.
better.
Yeah.
So I had a friend of mine, Achilles tendon problem, blah, 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 abroad, sent him to a friend, and then 6 months later I said, oh, it hurts. Do you do your exercise? No, don't have time. He ran a marathon before, couldn't run. A year later I saw him again and I said, how's your Achilles tendon? Oh, that's gone. That's completely gone. Yeah. So what did you do? Nothing. I just waited.
Yeah. Well, patience.
So, yes, but he didn't run. He didn't
Yeah.
run. So he went cycling. He went to the gym.
Right, yeah.
He did some exercise, but he didn't run. But he didn't do the specific.
Did he
treatment.
get back to running?
Eventually, he did.
He
did.
Eventually,
he did.
Yeah. I think I have a similar opinion, and I think that the benefits of exercise, for your cardiovascular fitness, for your general health and well, but for whatever it is that's going on in your life, the benefits clearly outweigh, in this case, I think, the risks of that plantar fascia rupturing. And the way I explain it to my patients is, think of, and we all say this, don't we? Think of pain, so no pain and 10 pain. It is not sensible to be running on 10 out of 10 pain, is it?
Yeah.
Nobody would enjoy it.
Don't take medication and go running.
No, exactly. So I normally would say around, and this is the same for Achilles and probably most injuries we see, probably 2 to 3 out of 10 is okay. Now, obviously, if you've got a stress fracture and all those things, you wouldn't do this. That's not the advice. But for plantar fasciitis, if you're in that, it's moderately painful, but you're quite comfortable, I don't have a problem with people running. It doesn't mean they can go and run a marathon. But actually, I think, the term, you need to listen to your body, because actually the pain you experience during, it's important that you're not experiencing too much pain. But actually, if you feel no pain after, you get no pain the next day, your morning stiffness is, you've clearly not damaged yourself. Yeah. So actually the pain during, but I think more importantly, are you getting pain after? If you're getting 6, 7 out of 10 pain, you're limping afterwards, that's probably not a good thing, is it? So it's finding that balance, because the other thing we haven't talked about that's important is, generally speaking, rest doesn't help. You know, you could lie in bed for 6 months with plantar fasciitis. As soon as you get out of that bed, it's going to hurt even more.
Probably even more, exactly.
Yeah.
That applies to a lot of conditions where the question, should I have a boot?
Yeah.
Well, you can have a boot. So
As in to wear a Beckham boot or a moon boot.
Exactly.
Yeah.
For some other condition as well, you wear a boot, so you're going to start limping. You might get hip and knee pain.
Yeah.
It's heavy. You can't do the normal things. And as soon as you take it off, it might be even worse.
Yeah.
And the boot is made for walking. So yeah, sit at home, do nothing. You could do that. But a boot or a cast, as soon as you go back to your normal routine, no, you shouldn't have the boot on in that condition. You should do your exercise that physio teaches you, that you got to do 3 times a day. Ideally, wear the right shoes. Try to be active. Try not to do too much heavy impact, but try to do whatever, cycling, rowing, swimming. You can do that. Work on the muscle. Work on the flexibility. And yes, if you can go jogging, feel some discomfort whilst you do it, even if it hurts a little bit afterwards, a bit of discomfort afterwards, that is still okay.
Yeah.
It needs to get better, 2 or 3, fine.
Yeah.
And it shouldn't last so long.
Yeah. We'll do a video as well, just trying to go through the exercises that we recommend for people to have a look at as well. Okay, I think we've probably... So the key message is probably make sure you don't have a stress fracture or something else, so get a good diagnosis. Try some of these things that we've talked about. Maybe throw a few things at it, bit of shockwave, change your footwear, modify your activity a little bit, but stay active. Maybe think about jogging less or going on a bike. And probably the big thing is be patient, because it is going to get better. It's just going to take a bit of time.
Don't be too patient until you get the diagnosis.
Yes.
So you should get the diagnosis, and then you know what it is. You need to know the pain in the heel is nothing to worry about.
Yeah.
So I get quite a few patients that want some imaging. Could it be something nasty? No. The nastiest thing you normally would get is a stress fracture.
Yeah.
But you don't see anything really worrying. So get the diagnosis and then be patient. Yes. Do
Perfect.
the things and you should be fine.
That sounds like very sensible advice. Martin, very, very, very much enjoyed talking about that, and hopefully that's given people, you know, a bit more information than they had before. And hopefully a few people start taking some of our advice and they get better.
Indeed.
Brilliant.
Thank you,
Thanks,
Chris.
Martin.
Good. Thank you.